Metastatic breast cancer is breast cancer that has spread outside of the breast and outside of the lymph nodes in the region of the breast, meaning the lymph nodes under the arm. So this could be breast cancer that has spread to the liver or the lungs or the bone or brain or other parts of the body. At least as of 2023, we don't have a cure for the vast majority of patients with metastatic breast cancer, meaning that we can't give a set amount of treatment and then stop that treatment and hope that the cancer will never come back. And so we give treatments really to control the disease. There's not really a typical prognosis. Some patients can live for many years with a metastatic breast cancer diagnosis, and for other patients, the treatments don't work quite as well. So if you have questions about your prognosis, I would encourage that you talk with your doctors, and also just to know that there certainly are many women and men who are living with metastatic breast cancer for years.
The types of metastatic breast cancer are determined by the receptors that are present on the breast cancer cell. And so that makes biopsy extremely important so that the pathologist can look at the breast cancer cell under the microscope and determine if the cells are staining positive for estrogen, progesterone, or a protein called HER2. Estrogen-driven breast cancers are positive for estrogen and/or progesterone, whereas HER2-positive breast cancers are strongly positive for HER2. If the breast cancer cells do not express estrogen or HER2, then they're considered triple-negative breast cancer. Metastatic breast cancer is usually diagnosed initially by imaging. And what I mean by imaging is usually we'll see an abnormality on a CAT scan, an X-ray, or a bone scan that makes us concerned that the breast cancer has spread outside of the breast. That concern would be followed up with a biopsy, which is extremely important in metastatic breast cancer because not only do we want to make sure that this is actually a breast cancer that has spread to other organs in the body, we also really need to know the estrogen, progesterone, and HER2 status because it can change from the primary diagnosis, and the treatment is solely dependent on that receptor status, at least in 2023. The treatment for metastatic breast cancer is solely dependent on the type of metastatic breast cancer that it is, which is determined by the estrogen, progesterone, or HER2 status. And it's also important to know that the treatment for metastatic breast cancer is rapidly evolving and improving every year. For estrogen-positive breast cancers, generally we start with hormonally based treatments, which can usually be given orally. For HER2-positive breast cancer, it's extremely important for us to target the HER2 protein, usually starting with monoclonal antibodies added to chemotherapies. And for triple-negative breast cancer, the backbone treatment is usually based on chemotherapies with or without immunotherapy, at least in the beginning. So the treatment of metastatic breast cancer generally includes systemic treatments, which are medications that are administered either orally or intravenously with the goal of controlling the metastatic breast cancer, prolonging life, and providing optimal quality of life for as long as possible. These systemic therapies can be delivered as standard of care. Standard of care are therapies that are already FDA approved, that have already been studied in the context of clinical trials. We also can offer medications based on clinical trials. And what clinical trials are is they're offering newer medications that we're hopeful may offer a future advantage compared to the current standard of care. And so clinical trials offer usually standard of care plus a novel or experimental medication that we're hoping would be superior in the future, but we don't know, which is the whole context of the clinical trial. Every medication that has been approved for metastatic breast cancer and all cancer has been approved because of clinical trials. The way that we monitor metastatic breast cancer is we start patients on a treatment that we hope will control their disease for a prolonged period of time. We get a baseline set of scans or imaging, usually a CAT scan and a bone scan or a PET CT scan. And we repeat that imaging after we start treatment at regular intervals, usually about every 3 to 4 months. And our radiologists, as well as medical oncologists, are able to compare the images and make sure that the breast cancer is stable, hasn't grown, hasn't spread to other parts of the body. And as long as that is the case, we generally continue the treatment as long as the patient is tolerating it.
At Dana-Farber, the patients with metastatic breast cancer all see medical oncologists who specialize in breast cancer and really care exclusively for patients with all stages of breast cancer. We also offer subspecialty services, so if you need either surgical services, radiation oncology, et cetera, that's also available on a breast cancer specific basis. And we also include access to quite a number of clinical trials, really trying to develop new therapies for patients who have metastatic breast cancer. In addition to the clinical expertise and the clinical trials, we offer a number of supportive services. For example, through our Embrace program, patients are matched to clinical trials. We identify opportunities for patients to have specialized testing to see whether they would qualify for some very targeted or focused personalized clinical trials. And then there are many support services to help patients with this difficult diagnosis, and that includes social workers, psychiatry, nutrition, palliative care, and other consultative services.
Dana-Farber has one of the only metastatic breast cancer programs in the country, and we see hundreds of patients facing metastatic breast cancer a year. Patients can be involve their care with Dana-Farber in multiple ways. There's the primary provider way, and what I mean by that is that the patient's primary oncologist is at Dana-Farber. Those patients will have their treatments at Dana-Farber, their disease monitored. With every visit, we have our Embrace coordinator screen them for clinical trials that may benefit them. And so that's the primary way. Oftentimes, patients live far away from Dana-Farber, and it is too challenging to have their primary treatment there. And in that case, we can serve more of a consultative role in their care where they have their primary oncologist more locally at home, but they can follow up with us either at regular intervals every couple of months, or they can follow up with us when their local oncologist tells them that it's time for a treatment change. And in that capacity, they would still need to come back and see us. We would also be able to screen them for clinical trials and make recommendations on the next course of action to treat their metastatic breast cancer.